What's up, my average med students? Welcome back to part 4. This is our surgery, high yield, CK, and shelf prep video. Hope this helps you. So go ahead and hit the subscribe button and press the bell icon to be notified for all future posts if you already haven't done so. If you like this content, please leave a like and share this with other average med students just like yourself. Let's get going. What is the most common indication for surgery in Crohn's disease? Small bowel obstruction. What's the most common type of melanoma? Superficial spreading. What is the most common type of breast cancer? Infiltrating ductal. What's the most common site of breast cancer? Upper outer quadrant. What is the most common vessel involved with bleeding duodenal ulcer? Gastroduodenal artery. What is the most common cause of bile duct obstruction? Choledocholithiasis. What is the most common cause of cholangitis? Bile duct obstruction, 2 out of 2, choledocholithiasis. What's the most common cause of pancreatitis? Alcohol. What is the most common cause of bacteria in stool? Bacteroides fragilis. What's the most common cause of small bowel obstruction in adults in the US? Adhesions. What is the most common cause of small bowel obstruction in children? Hernias. What's the most common cause of emergency abdominal surgery in the US? Appendicitis. What's the most common site of GI carcinoids? The appendix. What's the most common abdominal X-ray finding with small bowel obstruction? Air fluid levels. What's the most common electrolyte deficiency causing ileus? Hypokalemia. What's the most common cause of transfusion hemolysis? Clerical error, type incompatibility. What's the most common cause of blood transfusion resulting in death? Clerical error, wrong type. What's the most common cause of distant metastases of sarcoma? Lungs. What's the most common cause of shock in a surgical patient? Hypovolemia. What's the most common cause of esophageal perforation? Iatrogenic. What's the most common cause of anal fissure? Posterior anus is supposed to be posterior. What's the most common cause of large bowel obstruction? Colon cancer. What's the most common cause of type of colonic volvulus? Sigmoid volvulus. What's the most common cause of fever less than 48 hours post-op? Atelectasis. What's the most common cause of bacterial UTI? E. coli. What is the most common chest X-ray finding with traumatic thoracic aortic injury? Widened mediastinum. Most common abdominal organ injured in blunt abdominal trauma. Spleen. What is the most common abdominal organ injured in penetrating abdominal trauma? Small bowel. What's the most common benign tumor of the liver? Hemangioma. What is the most common malignancy of the liver? Metastatic. What's the most common cause of pneumonia in the ICU? Gram-negative bacteria. What is the most common source of bleed in epidural hematoma? Middle meningeal artery. What is the most common cause of lower GI bleeding? Upper GI bleeding. What is the most common hernia? Inguinal hernia, right to left. Right side more than left. What's the most common cause of esophageal laceration? Iatrogenic instrumentation, like endoscopic gastroduodenal scope. What's the mechanism of action for warfarin? Inhibition of synthesis of vitamin K dependent factors 2, 7, 9, 10, protein C and S. What are the uses for warfarin? Long-term anticoagulation. What are the 4 associated risks of warfarin? Bleeding, complications, teratogenic in pregnancy, skin necrosis, and dermatitis. What lab tests do you follow for warfarin? Warfarin's effect. PT reported as INR. What's the classic therapeutic INR for warfarin? INR of between 2 to 3. What's the half-life of warfarin? 40 hours. You'll need at least 2 days to see the change in PT. How do you reverse the action of warfarin? You stop the drug, start vitamin K, it takes time, and you can do fresh frozen plasma in emergencies. How long do you discontinue warfarin before surgery? About 3 to 5 days, and you start heparin and then stop heparin 4 to 6 hours pre-op. What is a clean wound? Elective, non-traumatic, primary closure without drain. What do you do for a clean contaminated wound? Operation on GI or respiratory tract without unusual complication or entry into biliary or urinary tract. What about contaminated wound? What are the 4 causes? Acute inflammation, traumatic wound, GI tract spillage, major break in sterile technique. What are the 3 dirty wounds? Pus is present, perforated viscous, and dirty traumatic wound. Complications of wound infections. What are the top 3? Fistula, sinus tracts, suppressed healing, and infection. What lab tests do you do for infected wound? CBC, blood cultures, imaging studies, and look for abscess. How do you treat the abscess? Incision and drainage and antibiotics. When do peritoneal abscesses occur? After laparotomy, ruptured appendix, peritonitis, anastomotic leak. What are the top 6 common sites for a peritoneal abscess? Pelvis, Morrison's pouch, subphrenic, pericolic gutters, and periappendiceal lesser sac. What are some signs and symptoms of peritoneal abscesses? Fever spiking with abdominal pain and mass. How do you diagnose peritoneal abscess? Abdominal CT or ultrasound. When should abdominal CT be obtained if looking for an abscess? Over 7 days post-op, otherwise abscess may just look like fluid collection. What are the CT findings for peritoneal abscesses? Fluid collection with fibrous capsule, gas in fluid collection. How do you treat peritoneal abscesses? Percutaneous drainage. Which abscesses do you not need to drain? Amoebiasis. What is a stitch abscess treatment? Subcutaneous abscess centered around SC stitch, drain and remove stitch. Necrotizing fasciitis is defined as bacterial infection of underlying fascia that spreads very fast. What are the causative agents for necrofash? Classically, it's streptococcus, but in practice, you see it's polymicrobial and anaerobes, especially gram-negatives. What are 9 signs and symptoms of necrofash? Fever, pain, crepitus, cellulitis, skin discoloration, blood blisters, leukocytosis, subcutaneous air, septic shock. How do you treat necrofash? IV antibiotics and debridement. You may need tetanus prophylaxis. How do you define parotitis? Parotid gland infection. What's the number 1 causative organism causing parotitis? Staph. What are 6 risk factors for parotitis? Age over 65, malnutrition, poor oral hygiene, NG tube, nothing by mouth, and dehydration. When does parotitis occur? About 2 weeks post-op. What are some signs and symptoms of parotitis? Hot, red, tender parotid, leukocytosis. What's the treatment for parotitis? Antibiotics, and you may need incision and drainage. How do you calculate hourly rate for maintenance fluids? 4-2-1 rule, 4 milliliters per kilograms for the first 10 kilograms, 2 milliliters per kilograms for the next 10 kilograms, and 1 milliliter per kilogram for every kilogram over 20. What's the most common adult maintenance fluid? You give D5 half normal saline plus 20 milliequals of potassium chloride per liter. What's the most common pediatric maintenance fluid? D5 quarter normal saline with 20 milliequals of potassium chloride per liter. Less normal saline because kids can't concentrate urine as well. Why is sugar added to maintain fluid? Prevents muscle breakdown. Best way to assess fluid status? Urine output, unless cardiogenic or renal dysfunction, then central venous pressure or wedge pressure. Minimum urine output for adult. 0.5 cc's per kilogram per hour. Minimum urine output for an adult trauma patient. 50 milliliters per hour. 2 common isotonic fluids. Normal saline and lactate ringers. Why do bolus fluids never contain glucose? It may cause hyperglycemia. Consequence of hyperglycemia in hypovolemic patients. Osmotic diuresis, worsened hypovolemia. What portion of 1 liter normal saline stays intravascular? After 5 hours, only 20% remains intravascularly. What common trauma resuscitation fluid? Lactated ringers. Most common IV fluid status post laparotomy. D5 lactated ringer for 24 to 36 hours. How long after laparotomy does the third space fluid mobilize back into the intravascular space? About 3 days. IV fluids used to replace duodenal or pancreatic fluid loss. Lactated ringers, patient has lost bicarb. Lactate is converted to bicarb in the kidney and replaces. Peptic ulcer disease is defined as gastric and duodenal ulcers. Possible complications of peptic ulcer disease: pain, hemorrhage, perforation, and obstruction. Percent of patients with disease that will develop bleeding: 20%. What bacteria is associated with peptic ulcer disease? H. pylori. Treatment of H. pylori in duodenal ulcers: combination of metronidazole, clarithromycin, ampicillin, and omeprazole. Sign of perforated posterior peptic ulcer: Valentino's sign, right lower quadrant pain with peritonitis. Duodenal ulcers, most common age group: 40 to 65-year-old. Duodenal ulcers, most common location: within 2 centimeters of pylorus in duodenal bulb, near gastric outlet, more direct exposure to strong acids. Duodenal ulcers, classic pain in response to food. Food relieves pain, decreased pain means duodenal. What causes duodenal ulcers? Increased production of gastric acid. What is the associated syndrome with duodenal ulcers? Zollinger-Ellison syndrome. What are some symptoms of duodenal ulcers? epigastric pain many hours after a meal, bleeding, back pain, nausea, vomiting, and anorexia. Duodenal ulcers diagnosis. History, physical examination, EGD, and upper GI series. If you have a currently bleeding ulcer, what are the indications for surgery when it's a duodenal ulcer? Greater than 6 units of packed red blood cells transfused, or greater than 3 units needed to stabilize. EGD finding associated with rebleed in duodenal ulcers. Visible ulcer in vessel, recent clot, active oozing. Duodenal ulcers, what's the medical treatment? PPIs, H2 blockers, and you require 4 to 6 weeks to treat H. pylori. Not currently bleeding, indications for surgery for duodenal ulcers. IHAP, intractability, hemorrhage, massive or relentless, obstruction of gastric outlet, and perforation. Perforated peptic ulcer symptoms. Acute onset, upper abdominal pain. Perforated peptic ulcers, what's the cause of pain in the lower quadrants? Passage of perforated fluid along the colic gutters. Physical exam signs, what are the four for perforated peptic ulcer? Decreased bowel sounds, tympanic or over liver, air, peritoneal signs, and tender abdomen. Signs of posterior duodenal erosion or perforation. Bleeding from gastroduodenal artery, acute pancreatitis. Sign for anterior duodenal perforation. Free air. Most common direction for perforation? Anterior. What are the 6 differential diagnoses for perforated peptic ulcer? Other things in the area could be acute pancreatitis, acute cholecystitis, MI, 2 out of 2 leakage, perforated appendicitis, colonic diverticulitis, and perforated viscus. Perforated peptic ulcer, what's the diagnostic imaging studies? Upright chest x-ray, free air under the diaphragm. Classic. What are the associated lab findings for perforated peptic ulcer? Leukocytosis, high amylase absorbed into the blood from the peritoneum. Perforated peptic ulcer treatment. NG tube, which decompresses, decreased contamination of the peritoneum, IV fluids, Foley catheter, antibiotics, and surgery. What's a gram patch? It's a piece of omentum incorporated into the perforation patch. If you have a hemorrhage and perforation during a perforated peptic ulcer, what do you do? Maybe kissing ulcer, posterior bleeding, and anterior with free air. What type of peptic ulcer presents just like pancreatitis? Epigastric pain radiates to the back, high serum amylase, posterior perforated duodenal ulcer presents just like pancreatitis. Lower GI bleed, what's the definition? Bleed distal to the ligament of Treats. What are the symptoms of lower GI bleeding? BR, BPR, and melena, plus or minus abdominal pain, plus or minus anemia symptoms. What are the top 5 signs of lower GI bleeding? Signs of acute bleed, bright red blood per rectum, plus a hemocult. Signs of blood loss would mean hypovolemic shock, orthostasis, plus or minus abdominal tenderness. Medicines to be on the lookout for lower GI bleeding. Coumadin, aspirin, and Plavix. Most common causes of GI bleeding, lower GI bleeding. So for the painless causes, there are diverticulosis, vascular ectasia, which are hemorrhoids, cancer, aortoenteric fistula, Almost always presents posteriorly, abdominal aortic aneurysm repair. And painful ones include ischemia, irritable bowel disease, intussusception, and ruptured aortic aneurysm. Lower GI bleeding, labs to run. CBC, Chem7, PT-PTT, type and cross, labs for dealing with bleeding. What's the initial treatment for lower GI bleeding? Fluid, volume resuscitation, transfuse as needed, Foley for UOP and NGT. What are the steps of diagnosing lower GI bleeding? First, you take a detailed history and presentation. Rule out the upper GI bleed with the NG tube. If no bile or blood, then you do endoscopy, EGD. You can also do anoscopy or proctoscopic exam. And for slow bleeds, you do a colonoscopy. And for fast bleed, you do arteriogram with TRBC, total RBC. So for lower GI bleeding, what's the best test to localize a bleed too active to see with a colonoscopy? Arteriogram. What's the rate of blood loss needed for sensitive total RBC scan? Greater than 0.1 milliliters per minute. Rate of bleeding needed for positive and negative grams. Greater than 0.5 milliliters per minute. Treatment of vascular ectasia or polyp. Laser electrocautery, local epi injection. For lower GI bleeding, treatment of known massive recurrent bleeding site. Segmental resection of bowel. Lower GI bleeding, surgical treatment of massive lower GI bleed without localization. XLAP plus or minus small intestine enteroscopy and total abdominal colectomy is the last resort. How many lower GI bleeds stop spontaneously? About 80-90% of the time with resuscitation, but they often will recur. How many need emergent surgery for lower GI bleeding? About 10%. Does melena equal an active bleed? No, colon may store for a period of time and pass them later. What's the therapeutic advantage of a colonoscopy in a lower GI bleed? Option to cauterize the bleeds. Therapeutic advantage of an arteriogram for lower GI bleeding. May control bleeding with vasopressin injections. What's child's classification components? ABEEP, ascites, bilirubin, encephalopathy, albumin, and PT. Liver tumors, what's the most common liver tumor? Metastatic disease, 20 to 1 out of the times. Liver tumors, what's the most common primary malignant liver tumor? Hepatocellular carcinoma. What's the most common primary benign liver tumor? Hemangioma. What are the 3 common primary benign tumors of the liver? Hemangioma, hepatocellular adenoma, and focal nodular hyperplasia. What are the 4 common malignant tumors in the liver? Hepatocellular carcinoma, cholangiocarcinoma, angiosarcoma, and hepatoblastoma. What is a hepatoma? It's a hepatocellular carcinoma. What's a hamartoma in the liver? It's a white hard nodule, normal liver cells in abnormal arrangement. What is a hepatocellular adenoma histology? Normal hepatocytes without bile ducts. Hepatocellular adenoma risk factors. Women on birth control pills. Hepatocellular adenoma complications. Rupture and bleeding increase risk of hepatocellular carcinoma. Hepatocellular adenoma, how do you diagnose this? CT, ultrasound, plus or minus biopsy. Hepatocellular adenoma, what do you treat it with? Surgical resection, but it's benign, but cannot leave it there because it might hemorrhage. Hepatocellular adenoma in pregnant women, how do you treat this? Resect during the second trimester. Focal nodular hyperplasia, histology. Normal hepatocytes with bile ducts. Focal nodular hyperplasia, classic CT finding. Liver mass with a central scar. Focal nodular hyperplasia, what are the complications? Pain, very little risk of cancer and bleeding. Focal nodular hyperplasia, what's the treatment? If it's symptomatic, you resect it or embolize. Otherwise, nothing. How do you define hepatic hemangioma? Benign vascular tumor. What's the diagnosis for hepatic hemangioma? How do you get there? You do CT with contrast, TRBC scan, MRI, and ultrasound. Hepatic hemangioma, what's the biopsy gonna show? Actually, you never biopsy this. It might hemorrhage. Hepatic hemangioma, what's the treatment? 90% of the time it's observed, resected if there's symptoms, hemorrhage, and you cannot rule out cancer. Hepatocellular carcinoma, what are the risk factors? 5 of them. So Hep B, cirrhosis, aflatoxin with aspergillus, steroids, and PVC. Hepatocellular carcinoma, signs and symptoms. Dull right upper quadrant pain, painful hepatomegaly, ascites, jaundice, portal hypertension. Hepatocellular carcinoma, what's the diagnosis? Ultrasound, CT, angiography, tumor markers. Hepatocellular carcinoma, what are the tumor markers? AFP. Hepatocellular carcinoma, most common way to get tissue diagnosis. CT-guided needle biopsy. Hepatocellular carcinoma, what's the most common metastatic site? Lungs. What's the treatment for hepatocellular carcinoma? Surgical resection. What are the 3 most common bugs that cause liver abscesses? E. coli, Klebsiella, and Proteus. What are the 4 most common sources or causes of liver abscesses? Cholangitis, diverticulitis, liver cancer, and liver metastases. Liver abscess signs and symptoms. Fever, chills, leukocytosis with right upper quadrant pain, and increased LFTs. What's the treatment for liver abscess? IV antibiotics and then PCT drainage. What are the indications for operative drainage for liver abscess? Multiple loculated abscesses. PCT attempts have failed. Amoebic liver abscess, what's the number 1 bug and how does it spread? Entamoeba histolytica and fecal oral spread. Amoebic liver abscess, what are the signs and symptoms? Right upper quadrant pain, fever, diarrhea, hepatomegaly, no chills, like pyogenic abscess. How do you diagnose amoebic liver abscess? Labs, ultrasound, and CT. How do you treat amoebic liver abscess? IV metronidazole. What are the indications for surgical drainage for amoebic liver abscess? Refractory to metronidazole or peritoneal rupture. What are some possible complications of amoebic liver abscesses? In left lobe abscesses, erosion into the pericardial sac. This could be fatal. What's a risk factor for hiated liver cysts? Travel, exposure to dogs, cattle, and sheep. Not cats, sorry. Hiated liver cysts, what are the signs and symptoms? right upper quadrant pain, jaundice, right upper quadrant mass, no fevers and chills. What are the findings on abdominal x-ray for hiated liver cysts? Calcified cysts outline. What are the major risks and complications for hiated liver cysts? Erosion into pleural cavity, pericardial sac, biliary tree rupture into the peritoneum, and could cause anaphylaxis. What are the risks in surgical removal of a hiated liver cyst? So rupture and leakage could lead to anaphylaxis, so be ready to irrigate with hypertonic saline if it ruptures. How do you treat hiated liver cysts? Mebendazole with surgical resection. You never do percutaneous drainage on this one. How do you define hemophilia? Blood drains into the duodenum via common bile duct. What's the diagnostic triad for hemophilia? Right upper quadrant pain, upper GI bleed with a guaiac positive, and jaundice. Hemophilia treatment. Angiogram with embolization. Superior parathyroid glands, embryology. Fourth pharyngeal pouch. Inferior parathyroid glands, embryology. Third pharyngeal pouch. Blood supply of the parathyroid. Inferior thyroid artery. What is DeGeorge syndrome, and what's the role of the parathyroid in DeGeorge syndrome? Congenital absence of parathyroid and thymus. What cell types makes PTH? Chief cells. What is the action of PTH? It increases blood calcium via increasing phosphate wasting. How does vitamin D work? Increases intestinal absorption of calcium and phosphate. Primary hyperparathyroidism. Increased secretion of parathyroid hormone by parathyroids. High calcium, low phosphate, high urine calcium. Secondary hyperparathyroidism definition in labs. Increased PTH, 2 out of 2, decreased serum calcium. Calcium is decreased because of renal failure. GI absorption usually is low, serum calcium, and high phosphate. Tertiary hyperparathyroidism is defined as, and what do you see on labs? So it's going to be high PTH persists after secondary correction, and you have autonomous PTH secretion, and it's not responsive to normal negative feedback from calcium. How do you image parathyroids? Sestamibi scan, ultrasound, technetium scan, or CT MRI. Primary hyperparathyroidism etiologies. Adenoma, hyperplasia, and that leads to carcinoma. Hyperparathyroidism signs and symptoms. Hypercalcemia, stones, bones, groans, and moans with psychiatric overtones. What is a 33-to-1 rule for hyperparathyroidism? So most primary hyperparathyroidism patients have chloride to phosphate over 33 ratio, and then high chloride is 2 out of 2, meaning renal bicarb wasting. What is the imaging findings for hyperparathyroidism? Subperiosteal bone resorption, especially on the hand digits. Familial hypocalciuric hypercalcemia. What is this? It's an inherited condition that's autosomal dominant. It's asymptomatic hypercalcemia with low urine calcium, with plus or minus increased PTH. Glands that are affected in hyperplasia of the parathyroid. All 4. Glands affected in adenoma of parathyroid. Just 1. Glands affected in carcinoma of the parathyroid. 1. Treatment of primary hyperthyroidism with 2 out of 2 hyperplasia. Neck exploration, remove all parathyroids and reimplant some in the arm. Treatment of primary hyperparathyroidism, 2 out of 2 adenoma. Remove adenoma, biopsy all glands. Treatment of primary hyperparathyroidism, 2 out of 2 carcinoma. Remove carcinoma plus ipsilateral thyroid lobe and any enlarged nodes. How do you treat secondary hyperparathyroidism? Correct calcium and phosphate renal transplant, no parathyroid surgery. How do you treat tertiary hyperparathyroidism? Correct calcium and phosphate. If refractory to medication management, then you remove all parathyroid glands and reimplant a chunk in the arm. When do you need to rule out MEN in hyperparathyroidism? Hyperparathyroidism from hyperplasia. Carcinoma is associated with hypercalcemia. So it's breast cancer metastases, prostate cancer, kidney cancer, lung cancer, multiple myeloma, and pancreatic cancer. Lung cancer type makes PTH. That makes PTH. Squamous cell carcinoma makes PTHRP related protein. Most likely diagnosis with a palpable neck mass, hypercalcemia, and elevated PTH. Parathyroid carcinoma. Most others have non-palpable thyroids. Parathyroid carcinoma is defined as primary carcinoma of the parathyroid gland. Parathyroid carcinoma, what are the signs and symptoms? Hypercalcemia, elevated PTH, palpable parathyroid glands, neck pain, recurrent laryngeal nerve paralysis. Parathyroid carcinoma, what's the tumor marker? HCG. Parathyroid carcinoma, how do you treat this? Resection of the mass, ipsilateral thyroid, lobectomy, ipsilateral lymph node resection. What are some post-op complications of parathyroidectomy? Recurrent laryngeal nerve injury, neck hematoma, hypocalcemia, superior laryngeal nerve injury. What is hungry bone syndrome in regards to parathyroid carcinoma? After surgical correction of hyperparathyroidism, severe hypocalcemia as bones resorb calcium. Embryology of Meckel's diverticulum. Remnant of omphalomesenteric duct, vitelline duct. What is the average age at symptom onset for Meckel's diverticulum? About 2 years old. What are some complications of Meckel's diverticulum? Painless hemorrhage, ulcerative bleeding, intestinal obstruction, inflammation leading to perforations. What are some signs and symptoms of Meckel's diverticulum? Painless lower GI bleed, plus or minus abdominal pain or small bowel obstruction. What's the most common heterotrophic tissue found in Meckel's diverticulum? Gastric mucosa. What is a Meckel scan? It's a technetium scan to find gastric mucosa. When or how do you operate Meckel's diverticulum? Bleeding and obstruction resection with small bowel resection, and ulcer is actually opposite of diverticulum. What is the associated hernia with Meckel's diverticulum? Litter's hernia. Most common sign of pancreatitis on abdominal x-ray. Sentinel loops, inflamed loops of the bowel. Acute pancreatitis treatment. Nothing by mouth, IV fluids, NG tube, Demerol, PPI, and H2 blockers. Acute chronic pancreatitis, indication for surgical treatment. Chronic severe pain. Pancreatic cancer, what's the most common type? Pancreatic adenocarcinoma. Pancreatic cancer tumor markers. CA19-9. What's the most common islet cell tumor of the pancreas? Insulinoma. How do you diagnose a lymphoma? Cervical or axillary node biopsy. What cell type is associated with Hodgkin's lymphoma? Reed-Sternberg cells. What are the 4 types of Hodgkin's disease? There's nodular sclerosing, mixed cellularity, lymphocyte predominant, and lymphocyte depleted. Hodgkin's disease, what's the most common one? Nodular sclerosing. What's the best prognosis Hodgkin's disease? Lymphocyte predominant. How do you stage melanoma? So every pigmented junction requires formalin. That's the mnemonic. So epidermis, papillary dermis, junction of the papillary reticular dermis, and fat. Pediatric surgery. So thyroglossal ductal cyst. How do you get the diagnosis? Ultrasound. Brachial cleft cysts. Common location. Lateral to the midline along the sternocleidomastoid. Heart abnormality associated with pectus deformity. Mitral valve prolapse. Neurotumors, a usual location in adults and peds. Adults is going to be supratentorial. In kids, it's going to be infratentorial. What's the differential for a ring-enhancing brain lesion? Metastasis, abscess, glioblastoma multiforme, or lymphoma. Neurotumors, signs and symptoms. First, it's going to be neurological deficit, headache, seizures with vomiting, especially in the morning. Neurotumors, what are some diagnostic tests you can do? CT or MRI. When do you operate neurotumors? You need to establish surgical diagnosis, relief of increased intracranial pressure, relief of neurological dysfunction, 2 out of 2 tissue compression, attempt to cure via resection of localized tumor. Most common intracranial tumors in adults. Metastatic, gliomas, and then meningiomas are the third most common. Most common neurotumors in kids. Medulloblastoma, astrocytoma, and ependymoma. How do you treat gliomas? Surgical debulking followed by XRT. They are really fast growing and really malignant. Where do you find gliomas? White matter of the cerebral hemispheres. Meningiomas treatment. Pre-op embolization and surgical resection. Cerebral astrocytoma, signs and symptoms. Kids with lateral cerebral signs, ipsilateral discoordination, falling towards the side of the tumor, nystagmus and ataxia with cranial nerves 6 and 7 defects. Cerebellar astrocytomas, what is the treatment? Complete resection. Medulloblastoma, most common location. Cerebellar vermis in kids and cerebellar hemisphere in adults. Medulloblastoma, signs and symptoms. Headache, vomiting, increased intracranial pressure, signs with truncal ataxia. Medulloblastoma treatment. Surgery should debulk and XRT plus chemo. Most common pituitary tumors. Prolactinoma. Most common presentation of a prolactinoma. Bitemporal hemanopsia. Prolactinoma, blood prolactin levels. Over 30 means it's diagnostic. What's the medical treatment for prolactinoma? Bromocriptine, dopamine agonists. What's the surgical treatment for prolactinoma? . Transsphenoidal resection. What's the treatment of recurrent prolactinomas? XRT. What's the most common site for cervical disc disease? C6 to C7 over C5 to C6 over, and then C7 to T1. Cervical disc disease symptoms and signs and symptoms of lesion at C7. So you're going to have decreased tricep reflex strength, pain from the neck, and index and middle fingers. Cervical disc disease, signs and symptoms of lesion at C6. Decreased biceps and brachioradialis reflex strength, forearm flexion, weakness, pain in neck, and radial forearm thumb. Cervical disc disease, signs and symptoms of a lesion at C8. Weakness in the hand muscles, pain in the 4th and 5th fingers, ulnar nerve. Alright guys, that about wraps it up. We did about 265 cards today. Stay tuned for part 5 if you don't want to miss out, and I really hope this is helping you. If you have any comments or suggestions or even any corrections to any wrong information that I may have presented, please go ahead and leave a comment down in the comment section below. And have a great day, guys. Bye-bye.
It's all in our head. Fear and frustrations, chest pain sensations, I know.